Hello, this is another lecture. This time it's lecture. This is now the lecture about the abnormal uterine bleeding, and that comprises two parts. The first part will deal with, firstly, just a one-page summary of the normal female cycle, the incidence of abnormal uterine bleeding, AUB at different ages, and I'll limit myself today to women just after the menarche and before the last menstrual bleeding. Then we address an important topic, postcoital and instrumental bleeding, and then the heavy menstrual bleeding. And we focus firstly on the symptoms and what findings there are on examination. The overview of part B, we continue with heavy menstrual bleeding and deal with the diagnostic workup. And then we describe the phenomenon unexplained uterine bleeding, which was called dysfunctional uterine bleeding in the past. An important topic is, of course, what management options do we have available, expectant, medical and surgical, and what option to choose for what woman in what circumstances. And we finalize, of course, with a summary. The normal female cycle. Short summary. Here we see what happens in the Uterine pituitary gland. This is the first part of the cycle in the ovary, which is called the follicular phase. Follicles grow, ovulation takes place halfway through the cycle in case of a regular cycle of 28 days. Ovulation takes place and the corpus luteum phase commences when we look at the ovary. One level down, what hormones are produced in the first half is predominantly estrogen, estradiol. In the second half, the estradiol continues, and it's now, we notice there's an increase in progesterone as well. Look at the endometrium. After it's being shedded during the menses, the baseline commences to grow and the influence of estradiol, and that's what we call the proliferal phase. The endometrium starts thickening. After the ovulation, under influence of progesterone, we describe the changes in the endometrium secretory phase, so the endometrium prepares for possible a fertilized ovum. This is the basic summary of the normal female cycle, which is being discussed and presented in much more detail in the dedicated DAROGA lecture, The Female Cycle. The incidence of abnormal uterine bleeding in the reproductive age, roughly 10 to 30% of women have at least one occasion of abnormal uterine bleeding. So it's a frequent presentation, not only in the general practice, but quite a frequent presentation as well in gynecological practice. We discern heavy menstrual bleeding, HMB, postcoital or instrumental bleeding, intermenstrual bleeding, as the most common phenomenon. When we look at the different ages, firstly we discuss shortly after the menarche what typical abnormal uterine bleeding can take place. Secondly, we focus on the reproductive years thereafter. And thirdly, women present as well with abnormal uterine bleeding quite often before the last menstrual period takes place. Let's assume now we see a young lady of 13 years and she presents with heavy bleeding per vagina. Her history, her menarche commenced 9 months ago. Her last menstrual period was about 6 weeks ago, and her cycle is quite irregular, hovering between the 4 and 6 weeks. She has no pain and she is sexually not active. What is your working diagnosis and why? This is a typical presentation of an anovulatory bleeding. The ovary is producing estradiol, stimulating the endometrium to grow, to proliferate. However, there is no progesterone action to oppose this effect. so the endometrium continues to grow and sheds in a very irregular fashion. The fact that there is no pain, as we will see later on, points at anovulatory bleeding because of the lack of progesterone and prostaglandin activity. How would you manage this case? Well, if the ovulation is not taking place, we can prescribe her oral progesterone, for instance, medroxyprogesterone acetate, MPA, 5 mg tablets twice a day for 10 days. With this regimen, we mimic, as it were, the ovulation, and hence, what would you tell her and, of course, her concerned mother? Of course, if she starts taking the pills, the bleeding should cease or be considerably reduced, and important that you warn her for a most likely heavy withdrawal bleeding after she discontinues with the medication, so after she completed the course of 10 days. So this will be a typical response, and that confirms your working diagnosis and ovulatory bleeding. We are dealing now with the chapter Adolescent Abnormal Uterine Bleeding. Shortly after the menarche, most women have irregular periods or periods which are longer than 6 weeks apart and sometimes even more than 6 months apart, oligo or amenorrhea. And ovulation is the most likely cause. It has probably to do with the immaturity of the hypothalamic pituitary ovarian axis. 80% of women experience some irregular bleeding in the first year after the menarche. Organic disease is rare. We keep that in the back of our mind, but that's not what we are looking for in principle. If a woman would be sexually active, exclude pregnancy and STI. And of course, when her mother or parent, one of the parents, is present, very important to assess that in a very confidential way. Usually this temporary anovulatory cycles that usually resolve spontaneously, so explanation of the underlying mechanism and reassurance is warranted. Time will resolve because we assume that the maturation of the LHRH release, LH and FS release from the pituitary ovarian axis will actually improve as time progresses. If ongoing irregular bleeding, a combined oral contraceptive pill can be prescribed, and by the way, and time eventually will do its beneficial work. So what is typical for an anovulatory bleeding? It's non-cyclical, it's irregular, it's painless and heavy. Why is that so? There is continued proliferation from the endometrium, unopposed by progesterone, that should read an O, and there is focal necrosis with partial shedding of the proliferative endometrium. Due to the absence of progesterone and prostaglandin effect, there is one hand less vasoconstriction, hence heavy bleeding, and less uterine contractions, hence painless bleeding, no typical cramping uterine pain. Second part now is what are common abnormal uterine bleeding patterns in the years thereafter. The most common cause is a benign organic disease of the uterus, and that is particularly fibroids, leiomyomata, 2 polyps, or adenomyosis. As always, it's important to exclude that we're dealing with a pregnancy, because that would result in a completely different approach. Important to check whether the pap smear is up to date and was negative, to look at a cervical cause of the bleeding. What the third stage is the woman a year or so before her last menstrual period. The same phenomena takes place, so as shortly after the menarche, and ovulatory cycles, oligomenorrhea, sometimes 3 months of no periods and then a few weeks of heavy periods. So quite often due to anovulation. Now the cause is that there's a decreased number of ovarian primordial follicles in the ovary, and hence there is an increased resistance to FSH. And the meteor polyps in this era are more common. And of course, we have to consider as well malignancy or pre-malignancy. For instance, endometrial hyperplasia and endometrial cancer could occur. However, the incidence is higher at a more advanced age. For risk factors, I would like to refer you to the DAROGA post-menopausal bleeding videos. Next topic is post-coital and intermenstrual bleeding. Examination, important that we thoroughly inspect the vagina and the cervix in particular, and we ask ourselves, do we see a lesion anywhere, a mass or even ulceration? It's probably appropriate to repeat the pap smear, if not recently done. We can ask ourselves, is an ectropion visible? Ectropion is shown in this picture. We see here the magnification of the cervix in a lady who has an intrauterine device. Here we see the strings. This red circle represents the endocervical cells, and outside of this circle we see the squamocolumnar cells, the squamous cells. So the transition here is the squamocolumnar junction. The red part here is described as an ectropion, which means the cylinder cells have presented themselves outward, moving outward from the cervical canal. It's physiological, does not warrant treatment in general. A polyp is a second possible cause for postcoital and intermenstrual bleeding. Here we see magnification through colposcopy. This is an endocervical polyp. Note the very clear cervical mucus, and here we see precisely the squamocolumnar junction. Columnar epithelium here to the right and the squamous cells over here. And this area here depicts the transformation zone. So a polyp can be seen quite easily, is almost always benign and can be removed quite easily with a polyp forceps in the clinic. In infection, this picture shows completely in contrast to the previous one, yellowish, greenish mucus, leukorrhea dripping from the cervix, and this is a very typical picture for a lady who's diagnosed with gonorrhea. Here we see, by the way, as well an ectropion, the red area, and outside is the squamous cells. So this is the squamocolumnar junction. For this lady, of course, and for ladies who present with postcoital bleeding and intermenstrual bleeding, taking of endocervical swabs or PCR for STI is appropriate. It's important that we take endocervical material so we have cells in the swab, because gonorrhea and chlamydia, they harbor inside the cells. If no obvious explanation, it's appropriate to refer a lady for colposcopy to have a closer and more detailed look at the cervix to try to find out the explanation for the bleeding above. Last but not least, this is a picture of a lady with cervical cancer. We see debris on the cervix, and we see some ulceration and some bleeding. Why is this picture presented as the last one? Here in Australia and in high-income countries, this is a very rare condition. But let's not forget, if you look at the world map, here is the overview of the estimated cervical cancer incidence in the world in 2012 per 100,000 women. And we see the dark blue areas where more than 30.2 per 100,000 women are diagnosed with cervical cancer. Interesting, so the high incidence areas are particularly Africa, some countries in South America, and also Middle America, and India and parts of the Soviet Union. In our area, Papua New Guinea and East Timor, especially East Timor, has a very high incidence. So let's keep in mind that cervical cancer is uncommon in the high-income countries like Australia, Western Europe and North America, but it's still raving in other parts of the world. No vaccination, no cervical cancer screening with pap smears and whatsoever. The next topic, heavy menstrual bleeding. In the past, that is commonly described as menorrhagia. I would think it's better to use a descriptive term such as heavy or prolonged menstrual bleeding because it makes clear to everybody what we're dealing with. But you will see in many textbooks the word menorrhagia. What exactly the causes of menorrhagia is quite often not understood, is not yet explainable. Further research should elicit that for us. Usually the normal hemostatic mechanism means there's constriction, vasoconstriction of endometrial arterioles and or myometrial arteries thanks to a very potent vasoconstrictor and myometrium constrictor agent is prostaglandin F2 alpha. There is formation of platelet and fibrin as an hemostatic plug to close off endometrial vessels. There takes tissue regeneration place. Prostaglandins, inflammatory cytokines, and resulting in myometrial contractility. And if that works all well, then there is an orderly collapse of the functional layer of the endometrium and hemostasis is achieved. What is the definition of heavy menstrual bleeding? In principle, her experience, her story will tell you. The lady will describe to you that she will bleed through her clothes or onto her bedding at night, also described as flooding. She needs to change her sanitary protection every 2 hours or more, or she needs to use double sanitary protection. And she would tell you that she passes large clots. The most important part of all these dot points is actually whether the heaviness of the period interferes with her daily life as a woman, such as going out, working, shopping, or, let's not forget, sexual activity. So this is described as the quality of life. So for us it's important to find out whether the bleeding is so heavy that it has an impact on her quality of life. In some practices they use menstrual pictograms trying to quantify how much blood loss there is. I personally don't use this very often, but just for completeness I give you here an overview. So there are 3 types of sanitary pads, the green ones, the purple ones, and the blue ones, the dark blue ones. And the woman can actually indicate how many of these she uses and how badly soaked they are. Publication in Fertility and Sterility in 2013. It is a way trying to quantify the blood loss. The scientific definition is that a woman loses more than 80 ml of blood per menstrual cycle. This is defined as excessive heavy blood loss. The ultimate proof will be if this happens chronically, then it results in iron deficiency anemia because her bone marrow will not be able to keep up with the loss. What are causes of heavy menstrual bleeding and ovulatory bleeding, as we already discussed before? Typical, of course, after the menarche and before the menopause. Another condition well known is polycystic ovarian syndrome. If these women have anovulation for a longer time, that results in hyperplasia of the endometrium, which even can result in atypia of the endometrium, atypia, complex atypia, and that is in itself a precancerous condition. So important in PCOS women to keep that in our mind. If they have prolonged anovulation, the risk for endometrial cancer is looming. Disorders of hemostasis, that means that the clot formation is prematurely broken down and the recanalization of the endometrial spiral arteries commences earlier than usual. What other causes do we know? Tumors of the uterus, very rarely tumors of the ovary, iatrogenic quite often, and coagulopathies. Coagulopathies are very rare. Tumors of the uterus benign, very common, submucous fibroids or polyps of the endometrium. Malignant endometrial cancer or sarcoma, quite rare. We keep that in the back of our minds. Then a tumor of the ovary, quite rare, is the granulosa cell tumor, which produces estradiol in itself and would, in women before the menarche or after the menopause, clearly show, those women would show signs of feminization. or premature puberty. Iatrogenic, yeah, we doctors prescribe progesterones, oral, or they administer intramuscularly, such as Depo-Provera, or subcutaneously, such as the Implanton rod, or intrauterine, such as the Mirena intrauterine system. And of course, women on warfarin, on anticoagulation, sometimes are over anticoagulated, which can result in bleeding, very rarely coagulopathies. Adenomyosis is another uterine cause. What symptoms do these women in a typical case present with? Heavy and painful menstrual periods, and at examination in a typical case one can find a symmetrically enlarged uterus, which is by manual palpation quite painful. What would histopathology show? Because that's the final proof. So after hysterectomy, you can find endometrial tissue, endometrial glands dispersed between the myometrium. Here I'll show you a histopathology picture. Here we see the myometrium, and these are glands, endometrial glands dispersed within the endometrium, so within the myometrium, so typical for adenomyosis. A difficult diagnosis, and sometimes the suspicion is there when you look with an ultrasound scan or an MRI, but the final proof is the histology as shown here. Very rare is coagulopathy, for instance von Willebrand's disease. By the way, the German name Erich Adolf von Willebrand suggests he's a German, but he was a Finnish doctor who published his finding in 1924. Von Willebrand's disease means there is a defective platelet adhesion and there's a factor VIII deficiency, and there are different forms. When especially would we think that we're dealing with von Willebrand's? In a woman who presents with heavy menstrual bleeding from the menarche onwards and persisting after the menarche. So we call it as well a primary heavy menstrual bleeding. What findings when we would examine a lady with a fibroid uterus? Abdominal examination could mean there is a mass palpable, sometimes just a few fingers above the pelvic rim, but sometimes even much higher. So a mass is palpable. At speculum examination, usually no abnormalities are detected. Sometimes, however, the cervix is displaced to either one side or more anteriorly, and it means with a speculum examination it's very hard or even impossible to visualize the cervix. Vaginal bimanual examination, in a typical case, the uterus is enlarged, has an irregular surface, and it feels like elastic solid rubber. It feels like probably a potato if you would compress a potato slightly. With all respect, this is probably, that mimics it quite well. This concludes the first part of the video Heavy Menstrual Bleeding.